Hi, this is Dr. Akhtar Amin and today's topic is corneal dystrophy and corneal degenerations. First of all, corneal dystrophy. The corneal dystrophies are a group of progressive and bilateral disorders. They are corneal opacifying disorders and they are associated with decreased vision. So they are progressive disorders and bilateral. And there is also associated discomfort. They are divided based on the biomicroscopical and histopathological features. They are divided into epithelial, Bowman layer, stromal, and descemet membrane, and the last one endothelial. So one or more underlying genetic abnormalities have been identified for most. So as a general rule, most types of corneal dystrophy, they are bilateral and they primarily affect one layer of the cornea and they are slowly progressive. First of all, epithelial dystrophies, in which the first one is Cogan dystrophy. Cogan dystrophy is also known as epithelial basement membrane dystrophy. As the name indicates, this consists of familial cases and isolated familial cases of epithelial basement membrane. So it is also known as map dot fingerprint corneal dystrophy. Since most patients seen in clinical practice have no documented family history of the condition, these corneal changes are now considered degenerative or secondary to trauma. So nowadays they are considered degenerative or secondary to trauma. The disease is often misdiagnosed principally because of the variable appearance. In inheritance, the condition is usually sporadic and these cases may be degenerations rather than true dystrophies, in contrast to the rare familial cases which are autosomal dominant. On histology, there is thickening of the basement membrane with deposition of fibrillary protein between the basement membrane and the Bowman layer. Basal epithelial cell hemidesmosomes are deficient. The onset is in the second decade of life. 10% patients develop recurrent corneal erosions in the third decade, and the remaining are asymptomatic throughout life. The occurrence of bilateral recurrent erosions with no history of trauma suggests basement membrane dystrophy. The signs: the lesions are often best visualized by retroillumination or sclerotic scatter. Over time, pattern and distribution varies. They may be absent or subtle in a fellow eye. Similar features can be seen with recurrent erosions from any cause, so it can be misdiagnosed. Dot-like and microcystic epithelial lesions. There are dot-like and microcystic epithelial lesions. There is subepithelial map-like pattern surrounded by a faint haze. Whorled fingerprint-like lines. Bleb-like subepithelial pebble glass pattern. Treatment is similar to that of recurrent corneal erosions. So this was epithelial basement membrane dystrophy, because there is thickening of the basement membrane and deposition of fibrillary protein between the basement membrane and the Bowman layer. Classically, epithelial hemidesmosomes are deficient. The next epithelial dystrophy is Meesmann epithelial dystrophy. It is a rare, non-progressive abnormality of the corneal epithelium metabolism, underlying which mutations in the genes encoding corneal epithelial keratins have been reported. The inheritance is autosomal dominant. The histology shows irregular thickening of the epithelial basement membrane and intraepithelial cysts. The patient may be asymptomatic. There may be recurrent erosions and mild blurring. There is a moderate tiny intraepithelial cysts of uniform size but variable density. Density is maximal centrally and extend towards but do not reach the limbus. The cornea may be slightly thinned, sensation is reduced. Treatment other than lubrication is not normally required. So this was Meesmann epithelial dystrophy. There are other dystrophies, epithelial and subepithelial dystrophies. They are very rare, like lash epithelial corneal dystrophy. Here you can see the whole configuration and densely crowded microcysts. And there is subepithelial mucinous corneal dystrophy, and the last is gelatinous drop-like dystrophy. There are corneal deposits of amyloid. So lash, subepithelial mucinous and gelatinous drop-like. The next subdivision is Bowman layer and anterior stromal dystrophies. The first type is Reese-Buckler corneal dystrophy. This may be categorized as anterior variant of granular stromal dystrophy, which we will discuss below. Reese-Buckler corneal dystrophy. This may be categorized as anterior variant of granular stromal dystrophy. This is also known as corneal basement dystrophy type 1. Corneal basement dystrophy type 1, CBD1. Corneal basement dystrophy type 1. The inheritance is autosomal dominant. The affected gene is TGFB1. There is replacement of the Bowman layer by connective tissue in this type of dystrophy. Replacement of the Bowman layer by connective tissue. There are several severe recurrent corneal erosions in childhood. The visual impairment may occur. There are gray-white geographic subepithelial opacities, most dense centrally, increasing in density with age to form a reticular pattern. For definitive distinction from Thiel-Behnke dystrophy, histopathology including electron microscopy may be required. Treatment is directed at the recurrent erosions. Excimer keratectomy achieves satisfactory control in some patients. Excimer keratectomy. So this is Reese-Buckler corneal dystrophy. The next Bowman layer anterior stromal dystrophy is Thiel-Behnke corneal dystrophy, also termed as honeycomb shape corneal dystrophy, and also known as corneal basement dystrophy type 2. Corneal basement dystrophy type 2. The previous was corneal basement dystrophy type 1. The Reese-Buckler was corneal basement dystrophy type 1, while Thiel-Behnke is corneal basement dystrophy type 2. Inheritance is autosomal dominant. The gene is TGFB1. TGFB1 is the same gene in the previous Reese-Buckler disease. Histology: the Bowman layer curly fibers on electron microscopy. Curly fibers. Symptoms: recurrent erosions in childhood. Signs: subepithelial opacities less individually defined than the granular dystrophy type lesions, which we will see below, seen in Reese-Buckler dystrophy. So they are less individually defined. They develop in a network of tiny rings or honeycomb-like morphology, predominantly involving the central cornea. That's why they are called honeycomb-shaped corneal dystrophy. Treatment is not always necessary. The next type are stromal dystrophy. Stromal dystrophies affect the stromal layer. The first type is lattice corneal dystrophy, TGFB1 type. The lattice corneal dystrophy is usually regarded as the classic form of lattice dystrophy. Clinical variants associated with more than 25 heterozygous mutations in TGFB1 have been described. Inheritance is autosomal dominant. Gene is TGFB1. In histology, there is amyloid staining with Congo red and exhibiting green birefringence with a polarized filter. On symptoms, there are recurrent erosions at the end of first decade in classic form when typical stromal signs may not yet be present. Blurring may occur later. Signs: there are refractile anterior stromal dots. Refractile anterior stromal dots. Here you can see refractile anterior stromal dots coalescing in a relatively fine filamentous lattice that spread gradually but spares the periphery. A generalized stromal haze may progressively impair vision. Corneal sensation is reduced. Treatment is by penetrating or deep lamellar keratoplasty is frequently required. Recurrence is not uncommon. So this was lattice corneal dystrophy. Next is lattice corneal dystrophy Gilsoline type, also known as LCD2 or Mary-Tuja syndrome. This is a systemic condition rather than a true corneal dystrophy. The inheritance is autosomal dominant. Gene is GSN. Histology shows amyloid deposits in the corneal stroma. Ocular symptoms: there is ocular irritation, late impairment of vision. The erosions are rare. So the lattice corneal dystrophy Gilsoline type, there are sparse stromal lattice lines spread centrally from the periphery and the corneal sensation is impaired. Systemic features are progressive cranial and peripheral neuropathy, mask-like faces, autonomic features. Homozygous disease is rare but severe. Keratoplasty may rarely be required in later life. So this was lattice corneal dystrophy Gilsoline type. The next is granular corneal dystrophy type 1 or classic type. Inheritance is autosomal dominant and gene is TGFB1. Homozygous disease give more severe features. On histology, there are amorphous hairline deposits staining bright red with Mason trichome. Symptoms are glare, photophobia, blurring as progression occurs. Recurrent erosions are uncommon. The signs: there are discrete white central anterior stromal deposits. They resemble sugar granules, breadcrumbs, or glass splinters separated by clear stroma. So there are white central anterior stromal deposits, resemble sugar granules, breadcrumbs, or glass splinters. There is gradual increase in number and size of the deposits with deeper and outward spread, but at the end sparing the limbus. Gradual confluence and diffuse haze lead to visual impairment. Corneal sensation is impaired. Treatment is by penetrating or deep lamellar keratoplasty is usually required by the 5th decade. Superficial recurrences may require repeated excimer laser keratectomy. So this was granular corneal dystrophy type 1. Next is granular corneal dystrophy type 2, also known as Avellino and combined granular lattice dystrophy. Inheritance autosomal dominant, gene TGFB1. Histology shows hyaline and amyloid. Symptoms: recurrent erosions, mild visual impairment, late feature. Signs usually present by the end of the first decade in heterozygote. There are fine superficial opacities progress to form stellate or annular lesion, sometimes associated with deeper linear opacities. So this is granular corneal dystrophy type 2. Treatment is usually not required. Corneal trauma accelerates progression. Refractive surgery is contraindicated. Refractive surgery is contraindicated in granular corneal dystrophy type 2. The next is macular corneal dystrophy. Inheritance is autosomal recessive. Gene is CHST6. Condition is relatively common in island. Histology: there are aggregations of glycose aminoglycans intra and extracellularly, stained with Alcian blue and colloid iron. The symptoms are early end of the first decade visual deteriorations. Recurrent erosions are very common. The signs: there are dense but poorly delineated gray-white spots centrally in the anterior stroma, peripherally in the posterior stroma. There is no clear delineation between opacities, which may be elevated. Progression of the lesions occur in conjunction with anterior stromal haze, initially involving the central cornea. There is eventual involvement of full thickness stroma extended to the limbus with no clear zone. Thinning is a fairly early feature, with the late thickening from the edema due to endothelial dysfunction. Sensation is reduced. Treatment is by penetrating keratoplasty. Recurrence is common. So this is macular corneal dystrophy. The next is Schneider or crystalline corneal dystrophy. Schneider corneal dystrophy. This is a disorder of corneal lipid metabolism associated in some patients with systemic dyslipidemia. The use of crystalline in the name is no longer recommended, as corneal crystals are not a ubiquitous feature. Inheritance: autosomal dominant, gene UBIAD1. Histology: phospholipid cholesterol deposits. Symptoms: visual impairment and glare. The signs: there are central haze in early feature, progressing to more widespread full thickness involvement over time. Subepithelial crystalline opacities are present in only 50%. Prominent corneal arcus is typical. Gradually progress centrally, leading to diffuse haze. Treatment is by excimer keratectomy or corneal transplantation. So after Schneider, the next is Francois central cloudy dystrophy. It is not certain that this entity is a dystrophy. It may be clinically indistinguishable from the degeneration, posterior crocodile shagreen. Inheritance is autosomal dominant but not clearly established. Symptom: most always none. Sign: cloudy, grayish, polygonal or rounded posterior stromal opacities, most prominent centrally. Treatment is not required. Other dystrophies, congenital stromal corneal dystrophies, are fleck corneal dystrophy, posterior amorphous corneal dystrophy, pre-Descemet corneal dystrophy. The last type of dystrophies are Descemet membrane and endothelial dystrophies, in which the first one is Fuchs endothelial corneal dystrophy. This disorder is characterized by bilateral accelerated endothelial cell loss. It is more common in women and is associated with a slightly increased prevalence of open angle glaucoma. So there is open angle glaucoma risk and most common in women. Inheritance: most or sporadic. The occasional autosomal dominant inheritance mutation in COL8A2 has been identified in early onset variant and in the TCF4 gene in most other cases. The symptoms are gradually worsening blurring, particularly in the morning due to corneal edema. Onset is usually in the middle age or later. Signs: corneal guttata, the presence of irregular warts or excrescence on descent membrane secreted by abnormal endothelial cells. Specular reflection shows tiny dark spot caused by disruption of the regular endothelial mosaic. Progression occurs to a beaten metal appearance. Progression occur to a beaten metal appearance. Endothelial decompensation gradually leads to central stromal edema and blurred vision, worse in the morning. Epithelial edema develops in more advanced cases with the formation of microcyst in bullae known as bullous keratopathy, accompanied by discomfort. Rupture of the bullae is associated with marked acute pain secondary to the exposure of nerve fibers. Subepithelial scarring and peripheral vascularization may be seen in long-standing cases. Treatment: conservative options include topical sodium chloride 5% drop or ointment, reduction of intraocular pressure, or use of a hair dryer for corneal dehydration. Ruptured bulla can be made more comfortable by use of bandage contact lens. Cycloplegia, antibiotic ointment, lubricants, anterior stromal puncture may be helpful. Posterior lamellar descent membrane stripping endothelial keratoplasty or descent membrane endothelial keratoplasty or penetrating keratoplasty have a high success rate. Options in eyes with poor visual potential include conjunctival flap and amniotic membrane transplantation. Promising new treatment: topical rho kinase inhibitor with prior transcorneal endothelial cryotherapy seems to be stimulate endothelial cell proliferation and improve function. Cataract surgery may worsen the corneal status because of endothelial cell loss, and protective steps should be taken to reduce this. Modern machines using torsional phacoemulsification use less ultrasound time than the older machine, which use longitudinal phacoemulsification and are therefore less likely to cause endothelial loss. A triple procedure, combined cataract surgery, lens implantation, and keratoplasty, may be considered in eyes with corneal edema. Corneal edema is less likely to occur after cataract surgery if the central corneal thickness is less than 630 to 640 micrometer. Persistent corneal edema may follow cataract surgery in a patient with Fuchs endothelial dystrophy, particularly if the preoperative central corneal thickness is more than 630 to 640 micrometer. The second type is posterior polymorphous corneal dystrophy. There are three forms of posterior polymorphous dystrophy: PPCD1 to PPCD3. Association include iris abnormalities, glaucoma, and Alport syndrome. The pathological basis involve metaplasia of the endothelial cells. Inheritance is AD gene VSX1 in PPCD1. PPCD2 gene is COL8A2. PPCD3 gene is ZEB1. Symptoms absent. There is incidental diagnosis. Signs: subtle vesicular, band-like, diffuse endothelial lesions. Subtle vesicular, band-like, or diffuse endothelial lesions. Treatment is not required. Third type is congenital hereditary endothelial dystrophy, also known as CHAD or CHED, a rare dystrophy in which there is focal or diffuse thickening of the descent membrane and endothelial degeneration. CHED2 is a more common and more severe form of CHED1. CHED2 is occasionally associated with deafness known as Harboyan syndrome. Inheritance: CHED1 is autosomal dominant. Gene locus chromosome 20. CHED1 may not distinct from PPCD. CHED2 is autosomal recessive. Symptoms: photophobia, watering in CHED1, but not in CHED2. Signs: corneal clouding and thickening. They are neonatal in CHED2, develop during the first year or two in CHED1. Visual impairment is variable. Visual acuity may surpass that expected from corneal appearance. Nystagmus is more common in CHED2. Treatment: lamellar or penetrating keratoplasty. Differential is congenital glaucoma.